Are now going to start cornea part 2, and in this part we are going to discuss about the signs of the corneal disease. And so let's get started. The signs of corneal diseases are going to be superficial and deep. So superficial are punctate epithelial erosions, P's, and there is a punctate epithelial keratitis known as PEC, subepithelial infiltrates, superficial punctate keratitis, filaments, epithelial edema, superficial neovascularization, and pannus. So let's get started with the punctate epithelial erosions. Punctate epithelial erosions are the tiny epithelial defects that stain with the fluoresceins and rose bengal, figure 7.2a and 7.2b. Let's see. So this is a 7.2a. So this is a picture of the fluorescein staining and under the cobalt blue filter. So you can see that punctate epithelial erosions are getting stained. In the next part, you can see the punctate epithelial erosions are getting stained by the rose bengal. These are generally and early signs of the epithelial compromise. So how does the punctate epithelial erosions formed? So there is an epithelial compromise due to which there is a defect and there is an erosion that is very small. So these are called punctate epithelial erosion. Causes include a variety of stimuli. The locations of the lesion may give indications of etiology. So we can have a superficial punctate epithelial erosions, interpalpebral, inferior, diffuse, and central. So you can also see, according to the disease, we get where the punctate epithelial erosions are. So this is a cornea. You can get superior, you can get inferior, you can get interpalpebral region, and you can get diffuse, all of it, and you can get only the central one. So superior causes are anything which is superior, known as superior vernal disease, which is a superior disease, chlamydial conjunctivitis, superior limbal keratoconjunctivitis, floppy eyelid syndrome, and mechanically induced keratoconjunctivitis. As we go forward, we know that these are the diseases that usually affect the superior part of the conjunctiva and the cornea. Interpalpebral regions are dry eye, can also be inferior, reduced corneal sensations, and ultraviolet keratopathy. Inferior may be due to diseases like chronic blepharitis, lack of thalamus. Lack of thalamus is a condition. There is an inability to close the eye, so the inferior cornea get exposed. So you can get a inferior piece. And then we have eye drops toxicity, self-induced aberrant eyelashes, and entropion. Anything which causes affect the inferior side can cause inferior piece. Diffuse, some cases of viral conjunctivitis and toxicity to drops. Central are prolonged contact lens wear. Next is punctate epithelial keratitis. Punctate epithelial keratitis appear as a granular, opalescent, swollen epithelial cells with focal intraepithelial infiltrates. So basically, these are not erosions. These are the swollen epithelial cells. The epithelial cells get swollen up, and there is an so you can say this is a corneal layer. This is epithelium. This is stroma, and this is endothelium. So these get swollen up, and there is an with the intraepithelium there is an infiltrations. So this is punctate epithelial keratitis. They are visible unstained, but stained well with rose bengal and variably with fluorescein. So usually they do not stain. They only stain with rose bengal because rose bengal stain the dead cells and devitalized tissue. So that is why it gets stained with the rose bengal but not with the fluorescein usually. So what are the causes of the punctate epithelial keratitis? It can be infectious and miscellaneous. The infectious causes include, you can say, in viral, bacterial, mostly viral infections. So infections are adenoviral, chlamydial, molluscum contagiosum, early herpes simplex, herpes zoster, microsporidea, and systemic viral infection, measles, varicella, for example, measles, varicella, and rubella. So, and the miscellaneous causes include thigh-gation superficial punctate keratitis. We are going to discuss in the coming lectures what is the thigh-gation superficial punctate keratitis and eye drop toxicity. Next of the superficial signs are subepithelial infiltrates. So just remember, we are discussing about the superficial signs of the corneal diseases. So it can be P's, it can be PEC, it can be subepithelial infiltrates, so anything. So just remember, it's not necessary that all of them can be present in a single eye. Only one of the signs can also be present. So subepithelial infiltrates, tiny subsurface foci of a non-staining inflammatory infiltrates. Causes include severe or prolonged adenoviral keratoconjunctivitis, herpes zoster keratitis, adult inclusion conjunctivitis, marginal keratitis, rosacea, and thigh-gation superficial punctate keratitis. So what you have to remember is that any disease can cause it, usually viral, and very important about the herpes zoster. And what is it? Basically, it causes the subepithelial. So this is epithelium, this is endothelium side of the cornea. So subepithelial, there are the infiltration. How can you detect it? You can detect it by the slit lamp, and you can know where the layer is. Usually very commonly found in the adenoviral keratitis. And chlamydial can also be the cause, which is adult inclusion conjunctivitis. Next is superficial punctate keratitis. So superficial punctate keratitis is a non-specific term describing any corneal epithelial disturbance of dot-like morphology. So superficial punctate, or you are just seeing a random dots in the epithelium, so you can say it is a superficial punctate keratitis. Filaments. Now filaments are very important. It is a major signs that can be found in the dry eye in the cases of when there is an autoimmune diseases. So filaments are what are filaments? Filaments are the strand of mucus admixed with epithelium attached at one end to the corneal surface that stain well with the rose bengal. So see, filaments also stain with the rose bengal. Why? Because rose bengal stains the dead tissue. So basically it is a mucus discharge, mucus strand or mucus discharge that gets attached to the epithelium. And so we are going to see the picture. I think we have not seen the picture of punctate epithelial keratitis. So figure 7.2 C, you can see that this is a punctate epithelial keratitis. You can see that there is a swollen thing, and you can say that it is punctate epithelial keratitis. So next we can see is D is corneal edema with, so filaments are in the figure 7.2b. So filaments, you can see that it is in this. You can see that there is a, so you can see that there is an epithelium, and epithelium is one strand is attached to the epithelium, so you can say it is a filament. The unattached and moves with each blink. Gray subepithelial opacities may be seen at the end as site of attachment. Dry eye is by far the most common cause. Other causes include superior limbic keratoconjunctivitis, neurotrophic keratopathy, long-term ocular patching, and essential blepharospasm. So anything which causes a decrease in secretion or decrease in tear film can cause this condition. So you can say neurotrophic keratopathy, in which there is a nerve supply is lost nerve supply problem. So there is also a problem of dry eye. Ocular patching also causes dry eye. So these are the causes of the filaments. Epithelial edema. Subtle edema may manifest with the loss of the normal corneal luster, but more commonly, abundant tiny epithelial vesicles are seen. Bullae form in moderate to severe cases. So it is very important cause epithelial edema. So any edema is where you can see that the epithelial cells are edematous. So what happens is that there is a normal cornea is very clear. So when there is a loss of the clarity, it can manifest that there is some kind of edema. So small edema, how can you see? So basically in the slit lamp exam, when you see the small corneal edema, so you can see very tiny vesicles in the slit lamp on the cornea. Whereas in case of very large edema of the epithelium, you can see a well formed bullae. The cause is usually endothelial decompensation, but it can also follow the acute elevation of IOP, and the major causes of this is because the endothelium is not pumping enough water out. So that is why the epithelial cells become edematous. And why this happened? Because the endothelium is decompensated, and or when there is an increased IOP. Then there is so you can see the figure 7.2 D. 7.2 D, you can see the bullae. I think it's this bullus here present. So you can see the bullae present in the cornea. Next is superficial vascularization. Neovascularization. Superficial neovascularization is a feature of chronic ocular surface irritation or hypoxia, as in contact lens wear. Pain is described as superficial neovascularization accompanied by a degenerative subepithelial change. So you are going to differentiate what is superficial neovascularization and what is a pannus formation. So superficial vascularization is anything that causes the vascularization of the cornea superiorly is called the superficial vascularization. But if there is a degenerative subepithelial change in the cornea as well, then we call it pannus formation, and it is usually indicative because they are usually opaque. The cornea is opaque on that side. So you can see the figure 7.2E. You can see the superficial vascularization, but there is no edematous. But in this case, in pannus formation, there is a subepithelial change, which is, you can see that there is an opacity in the cornea as well. You can see there is a whitish thing as well as in here. Now we are going to start about what are the deep corneal signs. Deep corneal signs are infiltrates, ulceration, melting, vascularization, lipid deposition, folds in descent membrane, and desmatocele, break in descent membrane, and the sedal test. So what are the deep signs? Infiltrates are yellow or gray white opacities located initially within the interior stroma. So first we have studied about this superficial signs. Now deep, the disease is going deep into the cornea, so that is why we can say it is involving the interior stromal layer, usually associated with limbal or conjunctival hyperemia. So there is an associated hyperemia of limbus or conjunctiva. You can see in the figure 7.3a. 7.3a, yes, you can see that there is a very deep looking whitish lesions in the cornea, and there is a vascular hyperemia of the conjunctiva. There are stromal foci of acute inflammation composed of inflammatory cells, cellular and extracellular debris, including necrosis. So in the stroma, what happened is there is an inflammation. So what does the inflammation do? It causes recruitment of the inflammatory cells, cellular and extracellular debris, and it causes induced necrosis. The key distribution is between the sterile and infective lesion. So what we have to do is we want to identify if it is a sterile lesion or it is some kind of infective. Then we have to discuss about the pedal mnemonic. Pedal mnemonic is pain, epithelial defect, discharge, anterior chamber reaction, and location. We are going to see table 7.1. So characteristic of infective versus sterile corneal infiltrates. So first of all, we are going to study about the pedal, the pain. In infective, it is moderate to severe. It is more intense pain in the infective one, but the sterile it is usually mild. Epithelial defect very common and larger when present, whereas in sterile it is very much less common and tends to be small. So pain, epithelial defect, discharge, and discharge is purulent in infective cases, and in sterile it is mucopurulent. And E is for anterior chamber reaction. So in infective case, infective it is severe and sterile it is mild. Location in the infective one is central, and in the sterile it is mostly peripheral. So other we have not discussed this. In size tends to be larger in infective, and sterile it is smaller. Progression very rapidly progresses infective, whereas progression in the sterile is low. We have discussed about pain, discharge, single or multiple. Infective usually have a single location, whereas the sterile have a commonly multiple. Unilateral or bilateral, infective is usually unilateral, whereas sterile is often bilateral. Location we have discussed, and adjacent corneal reaction extensive in infective, and sterile it is limited. Next is suppurative keratitis. Is caused by inactive infection with bacteria, fungi, protozoa, and occasionally viruses. Non-infectious sterile keratitis is due to an immune hypersensitivity response to an antigen, as in marginal keratitis and with contact lens wear. So sterile is basically there is no bacteria, and in infective it is a bacteria which is infective, which is causing all this. Next of the deep corneal signs are ulceration. Ulceration refers to a tissue excavation associated with epithelial defect, usually with infiltration and necrosis. So ulceration is not only the epithelial defect, epithelial is damaged, whereas there is also the loss of the stromal tissue, which we call as ulcer, and there is a whitening and infiltration as well present in the other tissue, and there are signs of necrosis. Now there is a melting. Melting describes the tissue disintegration in response to enzymatic activity. So what is the difference between ulceration and melting? There in melting, it is the enzymatic reaction that is causing the melting of the tissue, destroying of the tissue. So that is why it is discussed as melting, often with mild or no infiltrate, for example peripheral ulcerative keratitis. Next is vascularization. Vascularization occurs in response to a wide variety of stimuli. Venous channels are easily seen, whereas arterial feeding vessels are smaller and require higher magnification. Non-perfused deep vessels appear as ghost vessels, best detected by retroillumination. So what happens is vascularization can also happen when there is in the corneal diseases, and in the deep corneal vascularization you can also see a ghost vessels can also be seen, and it is best detected during the retroillumination. Next is lipid deposition. It is very important. Anything that causes a chronic inflammation of the eye can cause the lipid deposition in the cornea. And how it happens is that there is a corneal vessels leak this lipid deposit, and they new vessels, and they causes the lipid deposition in the cornea. You can also we will also look at the lipid keratopathy in the coming lectures. So 7.3, you can see lipid deposition. Let's see figure 7.b and c. So in a B, it shows the ulcer. So in this picture, the ulcer is so not clear because you can usually tell by on slit lamp, and you can also tell by staining of the cornea. And in C, you can see the lipid are deposited, and there is a vascularization of the cornea. So these are the vessels, and there is a lipid deposition in the cornea. Next is fold in the descent membrane. It is very common disease. Any person who is doing training in the eye knows such striate keratopathy, which is very common after the cataract surgery, and there is a fold in the descent membrane which you appear as like this. It results from the corneal edema. Causes include inflammation, trauma, and ocular hypotony. Next of the corneal, deep corneal signs are descemetocele formation. It is very important, descemetocele formation. US spelling descemetocele, so it is not so important. It is a bubble-like herniation of the descent membrane into the cornea. So when a plugging defect that would otherwise be a full thickness. So the descent membrane tend to bulge, and this is what, so there is a loss of tissue, and the descent membrane, if intact, cause bulging, and this bulging is called descemetocele. You can see the figure 7.3e. You can see that there is some defect and there is a bulging of the descent membrane, and this is called descemetocele. Next is a break in the descent membrane. The break in the descent membrane may be due to corneal enlargement, haapstria, and very important that haapstria are horizontal break lines in the descent membrane. So any traumatic thing causes the break in the descent membrane, and when there is a break in the descent membrane, there are lines that form. And in haapstria, in infantile glaucoma, when the cornea is stretching due to the increased IOP, it causes a break that is horizontal. Whereas in a birth trauma, the breaks are usually vertical. So, or deformation such as keratoconus in birth trauma, acute influx of aqueous into the central stoma, acute hydrops can follow. So what happens in a case of keratoconus? There is a break in the, so this is a break in the descent membrane, and when there is a break in the descent membrane, the aqueous humor goes into the stroma, corneal stroma, and this is called acute hydrops. Then there is a Seidel test. The Seidel test demonstrates aqueous leakage. A drop of 1% or 2% fluorescein is applied on the surface of the eye. Using a slit lamp, the cobalt blue filter is used to detect the change in the color from dark orange to bright yellow green, secondary to localized dilution at the site of leakage. So in case of Seidel test, what you do, you put 1% or 2% drop of fluorescein, and you see the leakage dye. If the dye disappear because there is sudden leakage of the aqueous humor is leaking and it is washing away the dye, then it is the Seidel test positive. So that is it for the cornea part 2. We are going to discuss documentation and specular microscopy and corneal topography, principle of treatment in the next section. Thank you.